Myself, Dr. Bharat Bhosle. I am Senior Consultant Medical Oncologist at Bombay Hospital and I am working as a Director of Sunrise Oncology Center, Mumbai. Investigating urinary bladder or upper urinary tract cancer is a very important stage where a clinician go through a step of investigations. Patient first should do the urinary cytology, which can to some extent can detect the cancer cells in the urine cytology. The next step is to do cystoscopy or upper urinary tract scopy, wherein scope is put into a urinary bladder, and if you are suspecting the cancer is at ureter level, then there are special probes which can go and actually visualize at the level of tumors. If some suspicious or doubtful lesion is identified either in the upper urinary tract or in the bladder, that must be biopsied, and that biopsy should include the muscle layer. Why? Because that decides the stage of the cancer. Some cancers are superficial, which requires just excision, and based on the risk you instill certain injections like chemotherapy or immunotherapy such as BCG and newer therapy such as pembrolizumab. If the disease, the tumor is deep down involving the muscle, then it comes to a multidisciplinary team where chemotherapy also sometimes administered followed by surgery. The extent of surgery is decided by this stage. So cystoscopy and biopsy is the most critical stage in evaluation of bladder cancer. The next stage is, once you have confirmed that it's a cancer or a urothelial cancer, the next stage is what stage it is. So sometimes we do MRI, CT scans, and as and when required, based on the clinical suspicion, bone scan or PET CT scans, which are available easily in metros, are being done to know the exact stage of this cancer. That decide whether the patient will go for a radical surgery or only systemic therapy or a combination of chemotherapy followed by the surgery. So these steps in the evaluation of a bladder cancer or a urinary tract cancer are very important. First is confirmation of the diagnosis. Second step is staging of the disease to decide the intention of the treatment. So after the diagnostic and staging workup, there are certain steps needs to be taken, because the treatment of bladder or urinary tract cancer, that is urothelial cancer, has evolved in last 10 years. We have chemotherapy, we have targeted therapy, we have immunotherapy coming into picture, and stage 4 cancer, which are palliative patients, are living beyond 5 years with the use of different modalities. What is important is to confirm the diagnosis and get adequate tissue for evaluation. Sometimes we have to test these tissues, that is called as a biopsy, for newer tests like NGS, some mutations. If there are certain mutations, there are targeted drugs available. It's a mutation called as FGFR, and if certain tumors are PD-L1 expression is high in cancers like lung cancer and other cancers, it has actually shown that these biomarkers or MSI, this is again one more biomarker of genomic instability or tumor mutation burden. These biomarkers are evolving. In other tumors, we are regularly using these markers. In bladder cancer, we can do PD-L1, and there are different immunotherapy drugs based on what test is being used, what drug is available. That is very important. The reason is that these are very expensive molecules. Whenever we are using these molecules, at least whatever biomarkers are available, that needs to be tested on this tumor. The second thing is, with the use of these drugs, not all patients gets benefit. There are certain subset of patients. As I mentioned, PD-L1, high PD-L1 scores, patients do respond beautifully to these immunotherapy drugs, but not all again. In lung cancer, yes, the PD-L1 high, you get excellent responses. In bladder cancer, certain immunotherapy drugs are being utilized, even though you use chemotherapy first, get good responses, and as a maintenance. In that case, you need not do PD-L1. All the patients do get no response as a maintenance therapy. When the patient progresses on chemotherapy as a second line or third line, there are immunotherapy drugs. There are certain drugs which do need to look at the PD-L1. When patient is exhausted out of all these therapies, chemotherapies, immunotherapies, there are certain targeted therapy drugs. There are some new drug antibody conjugates which are coming up into picture. What we are seeing with use of different molecules, and which obviously needs proper tissue diagnosis, use of these biomarkers. Patients who used to live only for few months, now a fraction of patients, not all patients as I already mentioned, are able to prolong their survival, or they are living beyond 2 years, 3 years or 5 years, and that has been possible because of the proper investigation and use we use which is judicious. One after the other, you have to use all these molecules. At the same time, these are elderly patients, bladder cancer patients. No, there are patients who develop the cancer at young age, but most of these patients have comorbidities. Most of these patients have undergone the bladder resection. Their kidney functions are deranged. One has to be very careful while choosing these drugs, because most of these drugs which are effective, the important drug which is cisplatin, which is effective in bladder cancer or urothelial cancer, and as I mentioned, majority of the patients, if they are undergone the resection of the bladder, their kidney functions are already to certain extent are deranged. One has to be very careful while choosing these nephrotoxic drugs or monitoring during the course of these systemic therapies. So these things in recent past have revolutionized the treatment and outcome of bladder cancer or urothelial cancer, upper urinary tract cancer. And multidisciplinary team discussion where medical oncologist, a radiation oncologist, a nuclear physician, a surgical oncologist, with the help of social support, like we have social workers, cost of these therapies are exorbitant, and sometimes simple investigations patients can't pay from their pockets. So we have NGOs supporting, in bigger hospital, tertiary care hospital, for example in Tata Hospital there is a social worker cell. There are patient support groups, like we have head and neck patient support group, we have Lung Connect, where patients can discuss with each other, explore the options of participation into the clinical trials. Clinical trial is a big scenario where initially 15-20 years back patients hardly used to get any options to participate in clinical trial. There are very promising molecules where patient can enroll them with the informed consent into a clinical trial, and these molecules when come into clinical practice they are very expensive. One cannot have access to this, but this is also one of the recommended by bigger organizations like NCCN to participation into clinical trial is very, very important, not only in bladder cancer but in other cancers too. So the future for most of the cancer, including the bladder cancer, I think it is promising. Many drugs are coming up, though they are expensive now. In the future with biosimilars or generic, the drug cost is also going down. As I mentioned, there are social groups who are ready to support. One must come forward and do take advantage without any fear.